Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Efficacy of Methylprednisolone on Pain, Fatigue, and Appetite in Advanced Cancer Patients Using Opioids, a randomized placebo-controlled double-blind trial, by Arnof Paulsen et al. My name is Jeanette Vardy, and I'm a medical oncologist and researcher at the University of Sydney in Sydney, Australia. My oncological specialty is survivorship, breast and lung cancer. This podcast was co-written with Dr. Mira Agar, a palliative care physician and researcher at the University of New South Wales in Australia, who specialises in symptom control, delirium and clinical trials in palliative care. Almost all cancer patients experience pain during their course, with a third rating the intensity of their pain as moderate to severe. The World Health Organization analgesic ladder recommends a sequential three-step approach for analgesic administration based on pain severity. As inflammation plays an important role in the pathophysiology of pain, it is recommended that corticosteroids be considered as adjuvant drugs at each step of the analgesic ladder, where an anti-inflammatory effect is considered beneficial. Consistent with the guidelines, the use of corticosteroids to treat cancer pain is widespread, but there is limited evidence for their efficacy outside of specific clinical situations such as spinal cord compression or brain metastasis. Any benefit needs to be balanced with their potential to cause short and long-term side effects, which in some cases can be profound and impact on quality of life. The current study by Paulsen is a randomized, placebo-controlled, double-blind, multi-center trial evaluating the role of 16 milligrams of oral methylprednisolone twice daily for 7 days in treating pain in patients with advanced cancer. Participants were receiving regular opioids and had moderate to severe pain, defined by an average pain intensity ranging from 4 to 7 out of 10, and a life expectancy of greater than 4 weeks. The primary endpoint was average pain intensity at day 7, measured using a numeric rating scale. Secondary endpoints included analgesic consumption, fatigue, appetite, patient satisfaction, and adverse events. Of 592 patients screened, only 50 were eligible and randomised, and 3 of these were withdrawn and not included in the analysis. The mean age of participants was 64 years, and their mean Karnofsky index was 66. The majority had prostate, gastrointestinal, lung, or gynecological cancers. There was a difference in a number of baseline variables, including opioid requirements between the two groups, with 270 milligrams of oral morphine equivalents in the methylprednisolone group compared to 160 milligrams in the placebo group. At day 7, there was no significant difference in average pain intensity between the two groups, and no difference in change in pain intensity from baseline, daily pain intensity at rest, or opioid consumption. Significant improvements were found in fatigue and appetite from baseline to day 7 in those treated with methylprednisolone, with fatigue improving by 17 out of 100 points compared to a decline of 3 points in the placebo group, and appetite increasing by 27 out of 100 points versus 2 points, respectively. Patient satisfaction with treatment was also significantly better in the methylprednisone arm. Adjustment for baseline characteristics that were different between the groups, including pain intensity, use of neuropathic agents, and site of metastasis, did not change the overall results. No significant differences in adverse events between the groups were found, but it needs to be noted that many of the more serious side effects of corticosteroids are likely to occur with longer use. This may be less of a consideration for patients receiving terminal care, but is an important issue for those with longer expected survival. Limitations of the study include the small sample size, with only 10% of screened patients being eligible, raising questions of generalizability. And despite randomization, the baseline differences, particularly in opioid consumption. Although this was not statistically significant, this may be a reflection of the small sample size, as the clinical differences in morphine equivalents were large. Finally, as discussed above, the study was only looking at short-term effects, so efficacy or consequences of longer-term corticosteroid use could not be assessed. A recent systematic review by Paulson and colleagues found only 4 small randomized controlled trials that had evaluated the role of corticosteroids in advanced cancer patients on opioids. The results were inconsistent, and conclusions were limited by methodological challenges of the original studies. The studies were heterogeneous with regard to patient population, drug, dosing, and administration route. Only one study by Barrera and colleagues assessed pain intensity and analgesic consumption. They found a benefit for pain intensity and analgesic consumption with methylprednisone 16 milligrams twice daily, but the sample size was small. Corticosteroids are commonly used to treat fatigue. However, they have not been subject to extensive evaluation in randomized trials, and the studies which have been done have had methodological issues in relation to power and outcome measurement. More recently, a randomized controlled trial conducted by Yenara Jalingam and colleagues explored the use of 4 milligrams of oral dexamethasone twice daily compared with placebo for 14 days in patients with advanced cancer who had scores of 4 or greater out of 10 on at least 3 cancer fatigue-related symptoms, such as fatigue, pain, nausea, loss of appetite, depression, anxiety, or sleep disturbance. The improvement in fatigue from baseline to day 15 was significantly higher in the dexamethasone group compared to placebo. The authors note a limitation of this study was only 86 of the 120 participants completed the study to the primary endpoint, with several participants discontinuing study treatment, with 100 participants needed to achieve adequate power. Although these results are encouraging, concerns have been raised about longer-term toxicity at these doses, maintenance of efficacy, and indeed if a lower dose would also provide similar effectiveness. It is also important that treatment with pharmacological therapies are not considered in isolation, with consideration of all other aspects contributing to fatigue. Several randomized studies of varying methodological quality have shown a benefit of corticosteroids on appetite. However, the dose, duration, and route of administration have not been well established, with studies exploring oral and intravenous administration, with dosing varying 8-fold between studies. Studies with longer durations had high attrition rates, which may relate to toxicity or to progress of the underlying disease. In conclusion, adding this study to the extant literature, the evidence to support the use of methylprednisone for pain control in cancer patients remains weak, although its use for the treatment of fatigue and appetite may be more promising. Larger, well-designed studies are required to confirm the efficacy of this approach, to provide guidance regarding recommended dosing, and to determine whether corticosteroids can be safely continued longer term in cancer patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.